Good morning. I'm going to have everyone kind of get their seat and kind of settle in. It's a beautiful morning. There is no snow. I don't know what happened, but we didn't have it, so that's good. So it's an easy commute in. Good. Okay, well, my name is Jean Nagelkirk, and I'm the Vice Provost for Health here at Grand Valley State University. And on behalf of the Seidman College of Business Alumni Association and my office, welcome to the 10th annual Healthcare Economic Forecast. We're thrilled that you're here, and we think that you'll have a wonderful morning. We have information about the trends and future of healthcare and some research from our economics faculty. To kick off our event, we have, I will be introducing our president, Tom Haas. President Haas is a leader in higher education. He has done significant expansion for the programs throughout Grand Valley State University. He has developed the infrastructure by building state-of-the-art buildings and providing the resources and support needed for our excellent faculty and staff to prepare students who will be our practitioners and all sorts of business sectors with quality education. Tom Haas has supported students, faculty, staff in our community, and he's done an exceptional job. And many of you may know, but he is leaving at the end of this year, which is June 30th, and we'll miss him dearly, but he's going to come back and help us. So please help me welcome Tom Haas.
Thank you, Jane. And 10 years, usually it's been snowing every day. Each one, I don't know what happened, but I understand a little snow maybe in Holland, but great to have you here and looking around this particular topic for our community, as we know is very important. But I wanted to start off by saying a thank you to Jean. Jean has provided leadership for 12 years in this space. She's been at the university for 25. And I can't think of a better person who has been able to connect within the healthcare community in Grand Valley State University with the talent that she has provided. So thank you, Jane, for that. And another person that's new here today is we have our one of our new board members, Beth Emmett. She has actually two hats on with Spectrum and a new board member as well. And Beth, where are you? Congratulations. Thank you. So as Jean was saying, the 10th annual for this particular gathering, and I appreciate the collaboration that we have between the Office for Health and also the Seidman College of Business and its Alumni Association. The sponsors for this particular event, as you can see up on the slides here, Blue Cross Blue Shield of Michigan, Blue Care Network, and Priority Health. Recognize them, please. Well, this particular annual checkup, so to speak, the studies that we have been provided give us some insights into the counties and the trends in Kent and Ottawa, Muskegon, and Allen County. And the results of the research for this year will be presented by Professor Linde from GVSU and Kevin Callison from Tulane University, followed by a panel of healthcare experts too. So I think we're in for a good treat with what we bring to you with our agenda. One of the key phrases that I've heard Jean share time and time again is that healthcare and the opportunities we have to be achieved, the outcomes, through collaboration. And the Healthcare Economic Forecast provides a chance, maybe even a catalyst, to help us understand what those trends are and create the practices and the policies and the procedures that we need to have a healthy community. At the end of the day, that's, I think, what we all want to achieve. That's why I think we're here as well. We learn from one another in that space, and we then can create this environment so people have that healthcare services with the delivery systems, with the educational opportunities that we have here at Grand Valley and beyond. So I really do think that when we bring people together, whether it be the entities within the healthcare delivery, education, but it's also other business leaders that are of interest in this, government representatives, and the community members themselves. They want to know what's happening in this space because it provides a quality of life here in West Michigan that we do, in fact, cherish so much. Here at the university, we had last year the largest graduating class in our history. Over 5,000 students are now Lakers for a lifetime. We're now pushing 120,000 alums for a university that graduated its first alums back in 1967. So just scant 50 plus years ago, we have definitely made a difference here with the leadership that we had through these years in the community and with our board, and also bringing great faculty and staff together here to serve our students. We are noted with our student-centric model, and one that I'm very, very proud of as well. In fact, we, given the challenges, the demographic challenges here in the state of Michigan that you might be aware of, we welcomed the second largest freshman class this past August. And I'm mentioning that because if we look at all of our healthcare programs and the opportunities we have to study, we have over 9,000 students studying in some kind of health or health-related curriculum. We're providing the talent here for West Michigan and probably beyond that too in the state of Michigan with the array of programs that we have both at the undergrad and grad level. Those grad programs also include some of the programs in nursing at the applied doctorate level and those in the health professions, including, for instance, PT and others. So we are creating this talent pool for all of us here in West Michigan. And each program that we do offer has an intentionality to it to serve our students and to serve our region. And we use the advice and counsel in many to ensure that our curriculum is as relevant as it can be as well. And I do know that talking with the practitioners, I had a chance recently to go to one of our healthcare providers, and the PA I was working with, I said, well, will I ask this question or not? I said, sure. Where are you from? Where'd you get your work? Where'd you get your degree? And she looked at me. I don't think she knew who I was. But she says, I went to Grand Valley. I said, good. Now I'm in really good hands. So it's there, and it is very rewarding as well. So just in sum, Grand Valley is very much committed with our resources. When we opened up the Raleigh J. Finkelstein Hall in, I think it was May when we actually opened it up, I was thrilled to see the type of learning environments that include some technology, learning space for the faculty, research space as well for the faculty and students to come together on trying to solve problems that are necessary within the healthcare delivery systems and beyond. And I was just thrilled to see that space. And now if you go next to the Cook DeVos, you'll see another building coming out of the ground with the support of the state, which I appreciate very much. And that's going to be the Daniel and Pamela DeVos Center for Interprofessional Health. And that will be operational in the spring, I'll say that probably the summer of 2021. It's going to come out of the ground very, very fast. I've been watching that as it progresses, so I'm really thrilled with that. Again, opportunities provide the curriculum that are relevant in this space that we call healthcare. So I am, again, thrilled that you are here to learn from one another and learn from those folks that are going to be sharing some of their expertise with you. And I hope that at the end of the day, the networking that we have here and the collaboration that we need to have is the primary outcome of a gathering today. So thank you and Happy New Year.
Well, as President Haas expressed, we're especially pleased to be able to host this healthcare economic forecast, as we are the #1 provider of health professionals in the West Michigan region. Our students will be the practitioners that fill the need for the healthcare systems to do the work that they need to do and provide the safe, quality care that each of us need. So as you, like Tom said, as you see the practitioners, a lot of them will be from Grand Valley. He also mentioned that over a third of our students are in a health or health-related program. So not only do our professors do an exceptional job with teaching them, but we want to thank each of you today because each of you play a significant role in the students' development. Many of you are practitioners or administrators that allow the opportunity for the students to have clinical practice sites or clinical sites where they learn the skills to be expert practitioners. Others do precept, some do mentorship, some help do research. Students need to do research and they work side by side with you. So we appreciate whether you do that or provide resources because the students and faculty need you to develop experts and skilled clinicians. Not only will the students be practitioners though, they'll be healthcare leaders, they'll be the researchers that are getting together, and they will be the future educators so that our talent pipeline can stay filled. So again, thank each of you. There's a couple people I would like to either stand or raise their hand and be recognized. These two individuals are part of our sponsorship organizations. They work with us to give us input on the data, give us the data, and then answer questions on the data. So I'd like to recognize David Brown in the back from Blue Cross Blue Shield of Michigan. And I saw her somewhere, Jan Yu from Party Health. Here she is. So we'd like to thank both of them. And then finally, I'd like to thank Diane Dykstra. She's from my office, our special events coordinator. She does this, does the health check booklet, and she does all the health forums. So thank you, Diane. So this morning, we will start with two distinguished professors of economics presenting their research on health and the trends and costs implications for our community, followed by a presentation with a panel of healthcare leaders who will analyze and make predictions about the future. Specifically, they will talk about collaborations for providing quality, safe care, innovations in their organizations, and then look into their crystal ball and say what is going to happen in the future in healthcare in our region. So they will do a little bit of that, and then we'll get to ask them questions. Each of you has received a copy of the health check booklet, so you'll get to look more at that. But for those of you who are on live stream, you can go to the website that you registered for, and you can click on it, and you can follow along there as well. The information in this publication, as Tom has said, is intended to help look at health policy and develop that, inform what we need in the community as far as services, look at cost implications, and then look at how we deliver care. Now, for a brief introduction of our two researchers. First, Kevin Callison is an associate professor in the Department of Health Policy and Management at Tulane School of Public Health and Tropical Medicine. Prior to his appointment at Tulane, Kevin was here for several years, so we enjoyed that, and we're glad that he continues with us. Kevin earned a bachelor's degree in economics from Ohio State University and a master's and a doctorate in economics from the University of Illinois at Chicago. His research focuses on issues related to healthcare use, health insurance markets, and policy evaluation. Sebastian Linde is an assistant professor here in the Department of Economics and the Seidman College of Business at Grand Valley State University. Sebastian earned his bachelor's in economics and finance at Cardiff University in Wales before obtaining a master's in economics research at Cambridge University. He then completed a master's degree in mathematics at Loyola University in Chicago and then earned a doctorate degree in economics at Purdue. Sebastian's research interest includes industrial organizations, healthcare markets, health economics, and applied research. I'm going to have them come up now, but what I'd like you to do is there's cards on your seats. Jot down your questions. In a couple minutes before the end of the presentation, people will walk around and get those so they can answer questions. Please welcome Kevin and Sebastian.
Well, thanks for coming out this morning. It's great to see everyone. We're going to start by talking about some of the highlights of this year's research into trends in healthcare use and healthcare costs in Michigan. There are three sort of data issues that I want to highlight. The first is that we're going to start by looking at trends in healthcare behaviors. This is statewide data for the entire state of Michigan. We'll look at differences between the east side and the west side of the state. We'll also look at some trends in hospital use, hospital expenses, how Grand Rapids compares to other markets throughout the U.S. and how we compare to national averages. And then finally, we'll look at data from Priority Health and Blue Cross Blue Shield of Michigan and focus on people in the community with a chronic disease burden and look at how those expenditures and utilization for that group of people has changed over time. But one thing I wanted to point out when you're kind of listening to this and looking at some of the findings that we're going to present is what President Haas brought up as a demographic challenge for universities is the same demographic challenge that we're facing in healthcare, right? The population is aging in Michigan. It's aging in West Michigan. And we have some material on that in the book, but I think that's really something that's going to drive a lot of the results that we'll present today and how those things are going to change going forward, especially when you think about chronic disease burden and the population that's going to require medical management. So have that in the back of your mind as we present the results today. I'm going to let Sebastian start looking at trends in health behaviors in West Michigan and Detroit.
Okay, thank you, Kevin. So we'll start off by having a look at a healthcare overview for the Detroit and the West Michigan regions. So this is going to be looking at population health risk factors and access to care measures that are drawn from the CDC's Behavioral Risk Factor Survey. So we'll start off by looking at obesity rates. So this is classified as an individual having a BMI of 30 or above. And what we can see here for the two regions in question is that the trends have been fairly stable. For both the Tacoma and the Detroit regions, we see that it's been hovering around 30 or so percent. From 2011 through 2016. And if we look at more recent figures for the state as a whole, that figure is about 32.5% of the population that's obese. And it might be useful to compare that to the national average of 29.9%, highlighting the fact that there is still plenty of room for improvement when it comes to dealing with the adverse effects of obesity in the state. Turning over to current smokers. So in the data here, you're classified as being a current smoker if you have smoked at least 100 cigarettes in your lifetime and report smoking either every day or some days. What we see here is firstly that there's quite a divide between the Detroit and Tacoma regions here with more smoking prevalence in the Detroit region. Moreover, the trend in Detroit has been fairly flat across this time period. Whereas in the Tacoma region, we see a positive trend from 2013 to 2016 with a dropping smoking prevalence down to about 16% in 2016. If we look at more recent figures for 2017 from the survey for the state as a whole, that figure is about 20.4% for Michigan, which is considerably higher than the national average of 17.1% in 2017. Again, highlighting another area of potential improvement for the state as a whole. Now we're switching over to looking at healthcare access. So what we're looking at here is the age population of 18 to 64-year-olds who report having no healthcare coverage. And we see a very positive trend here, not surprisingly, given the rollout of the ACA and the exchanges that came with that and the expansion of Medicaid. So from 2013 to 2016, we see this trend, and it's fairly similar across the two regions in question, down to about a state average of 8.7 in 2016, notably below the national average in 2016, which was 11.9%. So a positive health marker in terms of our community. Now with greater coverage, we might also anticipate that people might have easier way to access care and also have increased utilization. So what we see here is the number of individuals reporting that they could not access their healthcare services due to preventive costs. So overall, that has been trending downward for the state. Here, looking at the Tacoma region, we see a similar story from 2014 through 2016, trending downwards in the right direction. And we see a similar trend for the Detroit region from 2013 through 2015, although we do note a slight uptick from 2015 to 2016 for the Detroit region. Turning over to individuals reporting that they have a usual source of care. So a primary care provider, to some extent here, we see a positive trend. So 2013 through 2015, we're moving in the right direction. More individuals are having access to a usual source of care. There's a slight leveling off for both regions, and we also note the gap between Coma and Detroit, with more people in the Coma region actually reporting having this usual source of care. When it comes to individuals saying that they had no routine checkup in the past year, we see a positive trend here. So back in 2011, across both regions, we had about 33% of the population noting that they did not have a routine checkup, whereas that has fallen down all the way down to 26% in 2016. So a positive trend given the potential benefits of early detection of potential health issues that people can have with routine checkups. And lastly, we turn to health status. So arguably a subjective measure, but we were asking people if how they would rate their own personal health, and here we have the percentage of the population responding that they only have fair or poor health. And that has been fairly stable. So firstly, what's interesting here is that it's consistently higher in the Detroit. More individuals there rating themselves as fair or poor than they do in the Coma regions. And moreover, what's interesting, given what we just saw in the last couple of slides, is we have increased coverage, we have increased access and utilization, we have more routine visits, but we don't rate ourselves as having better health necessarily. So that's for the healthcare overview, and I'm going to turn it back over to Kevin.
Okay, so we'll continue looking at these trends in utilization, but shifting our focus a little bit to the hospital sector. So the next section focuses on use and expenditures in the hospital sector. This data comes from the American Hospital Association. So they're collecting data on all their members, and we are taking this data and we're segmenting it by location. So we're looking at Grand Rapids, that's the light blue line in the picture that you see. We're looking at Detroit, which is the green line, the US as a whole, or the national average, that's the dark blue line, and then what we call the benchmark, which is the red line in the picture. And the benchmark is made up of an average of hospital outcomes in Buffalo, New York, Rochester, New York, Milwaukee, Wisconsin, and Louisville, Kentucky. And we chose these regions because if you look at things like population demographics, including age, the proportion of the population over age 65, you look at industry of employment, those are the areas in the US that match pretty closely with Grand Rapids. So you can think of the benchmark as sort of similar markets in terms of population. Maybe not similar in terms of the hospital structure, but similar in terms of the population. So the first figure shows hospital admissions per 1,000 population. And interestingly, I mean, Grand Rapids has far fewer hospital admissions per capita than some of these other regions. We're below the national average, pretty far below our benchmark, and also pretty far below the Detroit region. So it seems like for some reason, now this could have something to do with population health. It could be that we're healthier in Grand Rapids than some of these regions, and so we rely on hospital care less. It could be that we do more things outside the hospital in West Michigan, so people still get the care that they would get in these other regions, but maybe it's performed in a setting that's outside the hospital. But this tends to bode well for the community, as hospital admissions, we all know, are very expensive. And so having a low rate of hospital admissions is a positive sign for spending on healthcare in the region. Hospital expenses per admission. So this is not the cost, this is not the price you pay for a hospital admission, but this is what hospitals say on average it costs to treat a patient that comes into the hospital. So this is the cost from the hospital's perspective. And all of these areas, so Grand Rapids, Detroit, the national average, the benchmark, they're all kind of grouped together, and these costs are rising over time. Now, this is inflation-adjusted dollars, so we go from something like an average of around $20,000 in 2005 to up to between $25,000 and $30,000 in 2016. That's a pretty significant increase over that period, inflation-adjusted dollars. Now, part of this, what's causing this increase? Well, some of it, as we saw in the previous slide, is hospital admissions have been declining over time. So if you think about well, who is not going to the hospital anymore? Maybe it's the healthier people, leaving the sicker people to be admitted to the hospital. So it could be that the disease burden in the population for hospital admissions is increasing. It could be technological advancement, and technology acquisition is expensive, so that could be raising the cost of care. Could be inefficiencies involved with hospital care. It's not exactly clear what the reason is, but we do see pretty substantial growth in hospital expenses, and that's happening all throughout the country. This is one that I think is very interesting to look at because Michigan looks different than other places in the country. So this is outpatient hospital visits per capita. And what this means by an outpatient hospital visit, it doesn't necessarily mean you had to go to the hospital to get care, but it means you received care through a provider who was paid under the outpatient prospective payment system. In other words, the provider was affiliated with a hospital system in some way. That's what this is measuring. And if you look at the national average, this has risen slightly, but been pretty steady over the time span. So, something like around 2,000 visits per 1,000 population in 2005, roughly stayed the same through 2016, the national average. Where you see real growth is in Michigan, in Detroit and in West Michigan. And in fact, in both of those regions, use of outpatient hospital services has doubled over this 11, 12-year period. Now, does that mean people are using more care? Are we doubling the amount of care? Probably not. We can't tell exactly from the data, but probably this trend represents an increase in affiliation with hospital systems throughout the state of Michigan, with providers affiliating with hospitals. So you may be going to get care at your physician's office, but if the physician is now affiliated with the hospital system, then that's going to count as an outpatient hospital admission in this data. So probably that's what's being picked up in the Michigan data, since we're not seeing that increase in the benchmarking communities or in the national average. Emergency department visits, again, we track very closely in West Michigan with the national average and with our benchmark communities. Detroit, you can see, is a clear outlier here. So in the Detroit region, there's much heavier reliance on the emergency department as a source of care. This is going to show up throughout the expenditure metrics that we'll look at too. I think we all know that emergency department care is just like inpatient care, is expensive. And so the more emergency department care you use, that tends to correlate with higher expenditures, and we'll see that showing up. Medicare expenditures. So this is trying to get a sense of, okay, well, for the population that is over the age of 65, how much are we spending per person per year in this population? In other words, how much is the federal government paying for care for someone in this population? This is the pattern we've seen here had been, prior to the years included in the slide, had been increasing expenditures. The average person in Medicare, their expenditures were growing over time. Within the last few years, we've seen that decline somewhat. A lot of potential reasons for this. The increasing aging of the population, that's a lot of people turning 65. The people who are on Medicare at the lower end of the age distribution tend to be the lower cost Medicare people, so this could be driving some of the costs. Some people might argue that it's Medicare Advantage. There's been a big expansion in Medicare Advantage, and Medicare Advantage, which is included in this data, expenditures for people with Medicare Advantage may be better at managing care or reducing expenditures. Grand Rapids comes in right in line with the benchmark here again, and we're below the national average and far below Detroit. So on average for a Medicare patient, whether it's fee-for-service or Medicare Advantage in the Grand Rapids region, it's about $9,500 a year that the average person is using in care, compared to Detroit, which is closer to $10,500. And I like to put in, at the end, I like to put in some measure of quality. So we've seen these measures of utilization and expenditures. Here's a nice measure of quality. This is ambulatory care sensitive discharges, which oftentimes is used as kind of an overall marker of the efficiency of care in a region. Here, you want the number to be lower as opposed to higher. So the fact that Grand Rapids is the lowest of these comparison regions and that this number is declining over time, that's a good thing. An ambulatory care sensitive discharge means that you were discharged from the hospital for something that presumably could have been treated in an outpatient setting. Again, measuring the efficiency of care that's being received. And so we have, in Grand Rapids, compared to these other communities, fewer ambulatory care sensitive discharges per capita, which again is a positive. And this speaks well for the efficiency of care, the quality of care that we're receiving here, and also for the cost of care. Okay, now shifting focus again, we're going to look at major medical conditions. So this is focusing on people with chronic conditions. This is using data from Blue Cross Blue Shield of Michigan, Blue Care Network, and Priority Health. And the population, to keep in mind, the population that we're looking at here, these are generally people between the ages of 18 and 65 for the most part, people that are diagnosed with one of 6 chronic conditions. And we're going to look at the expenditures for these chronic conditions and the utilization for these chronic conditions. And we're going to compare, in some cases, Grand Rapids and Detroit. And all of these measures are looking at per member per year use. All right, so it's important to realize that Medicare population is not included in here. The Medicaid population is not included in here. This is the privately insured population, typically between the ages of 18 and 65. All right, so here are the conditions we track. We look at asthma, coronary artery disease, depression, diabetes, hyperlipidemia, low back pain, and then we have some comparisons with what are called healthy members, which are people who do not have a diagnosis of one of these conditions and who are between the ages of 30 and 39, to use that as sort of a baseline. There's a lot of colors and a lot of things showing up on here, but if you just look at the trends over time, you'll notice a pattern that for the most part, expenditures, again, inflation-adjusted expenditures for people with these conditions have increased over time. Notably, the last couple of years, we had some really large increases in expenditures for coronary artery disease. Last year, in using the data from 2016, coronary artery disease expenditures in West Michigan were approaching $30,000 per person who was diagnosed with that condition. What you see this year, though, for coronary artery disease, and you see it for some of the other conditions too, is decline in expenditures. And that's really the first time that we've seen that happening since we've been tracking this data, that expenditures for the chronically ill population have declined from one year to the next for coronary artery disease. So not something that we're used to seeing. Unfortunately, the data that we get don't allow us to understand exactly what is causing this decline, but you can speculate that there are a few things that might be driving this. So it could be that that maybe prices changed, maybe utilization changed, or maybe this is it's a healthier group of people who we're looking at now that are insured by Priority Health, Blue Cross Blue Shield, Blue Care Network, who have these conditions. So it's not clear which of those is driving that, but it's certainly a good sign to see expenditures fall. In this figure, we're again taking those same expenditures that I showed you before, but now we're looking at the component that is due to prescription medication. So, we're all concerned with prices and expenditures in prescription medication. This shows you if you take the average person who has any one of these conditions, you take their total expenditures through the year, and you look at what share of those expenditures are being driven by prescription medication. That's the red box here. The medical management, the other costs are shown in the blue. So probably not surprising, diabetes is the condition that has the largest reliance on prescription drugs and has the highest share of prescription drug expenditures. So for a person who's diagnosed with diabetes in West Michigan, a little more than a third of their expenditures throughout the year are accruing through prescription medication. It's about a quarter for hyperlipidemia. Again, the medical management through prescription medication tends to be prominent there. And this is something new that we added last year, so we don't have a very long time series here. We only have data from last year and this year, but our goal with this is to track these expenditures on prescription medication over time to see how important this outcome is in terms of determining changes in expenditures from year to year. So this is something that we'll present now as interesting to see now, but this is going to get much more interesting when we have a few more years of data to be able to track this. Okay, so how do we compare with the Detroit region? So taking Kent, Ottawa, Muskegon, Allegan counties, and then comparing them to the Detroit metro area, you can see that expenditures tend to be lower, conditional on having one of these chronic conditions. Expenditures tend to be lower on the west side of the state than the east side of the state. This has been the trend that's prevailed when we've looked at this in the past, although for certain conditions, especially coronary artery disease, this has tended to fluctuate. Sometimes West Michigan is more expensive, sometimes Detroit region is more expensive. This year, when we looked at costs for 2017, it's predominantly the Detroit region that is more expensive or spends more on average per person with one of these conditions than West Michigan. Okay, and then like the part that I think is most interesting is when you take these expenditures and these utilization measures and you break them down to show what the geographic variation in these measures looks like. All right, so we take, in this case, we're looking at coronary artery disease. We take that average annual expenditure amount and we look at how that varies across different zip codes throughout the state. And we control for some things here. So this isn't just raw expenditure. We take the zip code average education level, the average age in the zip code, and we control the average share of Medicaid patients, and we control for some of these things from zip code to zip code. So in other words, you can think of these expenditures as average expenditures conditional on age, education, and insurance status in a zip code. So red, obviously, that's going to represent higher expenditures. Green is going to represent lower expenditures. And for something like CAD spending, you see a really wide variation in spending by zip code. So if you're in one of these darkest green zip codes, on average, you're spending between about $15,000 and $23,000 a year if you're someone who has coronary artery disease. Compare that to the red zip codes where spending can reach $40,000 a year. Right, so pretty large variation here. And some of the variation is happening across pretty small geographic units. So, you go from one zip code to the next, and you may double spending on average in some cases. So getting a handle on what's driving this geographic variation, I think is important. I mean, those of you who, I'm not from Michigan, so those of you who are more familiar with the area and the intricacies of these different regions may see some patterns here that I don't see or understand some things. But I'll tell you, as we look through this, the east side of the state tends to have more higher expenditures, higher utilization than the west side. But if you focus on the west side, those zip codes to the northeast and southwest of Grand Rapids tend to have higher expenditures and higher utilization. Okay, so here's diabetes, same outcome, looking at expenditures now for people with a diagnosis of diabetes. And again, we see kind of a lot of that regional variation. You see more green on the west side of the state than on the east side of the state. Here, if you're in the lowest spending group, you're spending around $15,000, $16,000 per year compared to up to $20,000 for someone who is living in one of those red zip codes. If we look at expenditures for prescription medication for diabetes, remember prescriptions accounted for about a third of overall spending for a person diagnosed with diabetes. Here you really see the stark difference, right? I mean, this is not just diabetes prescription expenditures. This is prescription expenditures overall for someone diagnosed with this condition. But on average, so this is looking at the number of fills per year, you're having 55 to 65 fills if you're in the low region compared to 70 to 85 fills in the high region. Roughly that represents one more additional prescription per year that's filled 12 times if you're living in one of those red zip codes compared to the green zip codes. Right, so I think this is a really interesting disparity between the east and west side here in utilization rates for prescription medications. Lastly, something we were able to add this year, this is the first time we've had data on this. This is looking at telehealth visits, so annual telehealth visits for a person who has a diabetes diagnosis. And the takeaway here is that overall, telehealth is still, at least for someone who has a diabetes diagnosis, is still not being widely used, but there's a much greater reliance on telehealth on the west side of the state than the east side. And this may correspond to things like, rural versus urban differences. You tend to see the more rural zip codes here having higher use of telemedicine. But again, I think this is one of the other outcomes that is going to be really interesting to see how this develops over time and what this usage looks like over time. So again, the first year we've had the ability to look at this, already starting to see some interesting things here, but it'll be particularly helpful to see how this grows over time. All right, so I think I am out of time. We're going to end the presentation there, but happy to take some questions if anyone has it. Thank you. Okay, so the first question here, which I think is a really good question, and it's something we've discussed when we were putting this report together. Mental health. Mental health is not part of the report, and the impact it has on all aspects of health check. So can we talk a little bit about mental health? I agree completely with this. This is something that needs to be, I think, included in the report. We need to have some measure of use and expenditures for mental health, how mental health may interact with some other things. We do include depression in there, although that's, a very rough measure of mental health. We could do more, I think, to tease out some of the additional concerns that come along with that. There are some things in the book that I didn't include in the presentation that look a little more into how comorbidities interact and how that drives spending. So we do have some measures of, if you have depression and you have one of these other conditions, how does the combination of those things change expenditures? So some of that is in the book, but I completely agree that we can do more to look at the mental health issue.
So we had a clarification question about whether or not the Detroit data is for the region or just for the city. In terms of the healthcare overview, that's for the Detroit region consisting of the counties of Macomb, Oakland, and Wayne counties for that question.
We have another question on readmission. So have you studied hospital readmissions and conditions reported with higher than average readmissions? In this report, no. In my own research, yes. And I think the readmissions question is a really interesting question now because of the Medicare's efforts to reduce readmissions under the hospital readmission reduction program. There have been several of us doing research in that area, and a lot of that research just potentially got upended by a new paper that came out about a week ago saying that we've all been measuring readmissions incorrectly. So that was a bit surprising, but apparently there was another coding change that happened right around the time of the hospital readmissions reduction program, and if you account for this coding change, that tends to wipe out the improvements we've seen in readmissions from that most of us were attributing to the HRRP. So yeah, it's an area, an area that I have particular interest in, but we have not looked at that specifically for West Michigan or Detroit. Oh, okay. I thought this might come up. Somebody asked about the vaping, right? We show smoking rates, but we don't show any information on vaping. And vaping, again, is another area, or smoking policy is an area that I have some interest in too. And I've studied some effects of cigarette taxes and that sort of thing, but vaping is a little more complicated. So if you look amongst, traditional combustible tobacco use among teens, that has fallen off the table. There's, fewer than I don't know, 8% or so now of teens smoke traditional cigarettes, but of course vaping has escalated, and so there's concern about, well, what are the long-term effects of this? We don't really know. How do we reduce how do we try and reduce teen use of this thing? And it's a particularly challenging issue because on the one hand, vaping could be a tool for people who have been smoking for long periods of time to stop smoking the traditional cigarettes, which we know are more harmful than vaping. But on the other hand, you want to be careful not to initiate teen use. So I think some of the things that the FDA is doing, like trying to limit the flavors, I think that's going to help. I would like to be able to. It'd be interesting to see what this trend looks like in Michigan. The data that I know where you get information on vaping, like the National Youth Tobacco Survey, you can't get the granular data that you need to say, here's what's happening in Grand Rapids. For the state of Michigan, yeah, we could probably track that for the state, and maybe that's something that we'll add to the publication next year if we're able to. Michigan appears to be outpacing the nation in providers affiliating with hospital systems. Any thought on why? It makes sense strategically to partner with providers, right? I mean, more than financially, it makes sense because you can charge a facility fee and increase your reimbursements. But it also makes sense in terms of care coordination. And if you think about CMS trying to move towards a world where we're paying for quality and coordination of care as opposed to just paying for fee for service, then it does make sense to partner with providers who you can have maybe more control over how the care is delivered, and you can coordinate that care better. One of the interesting policy proposals here around this, though, around the financial aspects of this coordination, is that the Trump administration has proposed this the site-neutral payment policy that may take effect. There's a lawsuit now that M.C.E Health is part of challenging this to stop the site-neutral payment policy. But if that goes through, then you would no longer, if you're most off-site or off-hospital campus sites, then would no longer get this additional payment. So that then we'll know, I think that'll give us a good sense of whether the payment policy is what's really driving this consolidation, or whether it's concern over coordination of care and better management that's driving coordination. So I think that's something to keep an eye on, what happens with this site neutral payment policy and how that impacts additional coordination.
Yeah. Not too many, but I can see. So we have one question saying, is there similar data available for pediatrics as a subset? At least for the healthcare overview section that we're looking at, that only looked at the ages 18 and above. So we didn't have pediatric data there, although that's a really important subset to consider for future work. Have you been studying the impact of increased deductibles and copays, HSA utilization? Not as part of this year's report, but there's a lot of work being done in this area currently, but nothing that we have included this year.
Someone asked to clarify the terms cost and expenditures, and this is really important. So when we're looking at the measure of hospital costs, for example, that is not prices. All right, that's not the list price or the price that it's not even the negotiated price that insurance is paying. It's what the hospital says the cost of admission is. So if you ask the hospital, okay, on average, when you admit someone to the hospital, how much does that cost you in terms of resource use, in terms of staff, and that's the cost measure for that. For the expenditure measure for the major medical conditions section, that is the sum of what the insurance company is paying to providers throughout the year. So we add that up for everyone with that condition, we divide by the number of member months, and that gives us average annual expenditures for that member. Someone asked about out-of-pocket costs, and we unfortunately don't have that in the data that we're able to track what the change is in out-of-pocket expenditures. We've done some survey work in the past, asking people and asking firms, what's your average deductible, what's your average copay, coinsurance rate. We weren't able to do that this year for various reasons, but it's something that we'd like to continue to do in the future. We'd seen some interesting results when we tracked that in the past, so I think it's definitely something worth pursuing. All right. Okay. Another one that came up last year, and I think this is something that we have to add, and we didn't this year, but we should, is opioids. What's happening with opioid use? So it's the question asked, can you discuss suicides, drug use, opioids, and other illegal substances? And probably, I guess it was maybe a year or two ago now, very famously, there was this revelation that if you look at death rates for, in whites between the ages of 18 and 49, especially males, you compare the U.S. to other countries, you see death rates, mortality rates rising in the U.S. You don't see that anywhere else, and that has since been attributed to the opioid crisis. So tracking opioid use, the data are available to do that, and that's something we should add, and we will next year. There's no reason we can't add that to the book to look at how opioid use is changing in Michigan. Now, the thing to keep in mind with looking at opioid use data, and I think people often fail to see this when I talk about this subject, is that opioid prescriptions have fallen over the last 4 or 5 years. There's far fewer people being prescribed opioids. But that doesn't mean that people aren't substituting to heroin and these other illegal substances that are much harder to track. So I do think it's a good idea for us to get the data on opioids that we can get, and we can show you that data, but that's only one part of the story. So combining that with data on things like overdose deaths from other substances, I think is an important addition to the publication.
So we have a question with regards to patents. Can you provide some insight into the decline in the number of medical patents? So we didn't have time to include this in the discussion here, but if you look at the actual graph, you'll see a huge decline in the number of patents that have been issued since 2014 in the region. And while we don't have like a good answer for why we've seen this decline, because it is as severe as it is, we've seen that the number of patents have fallen and the number of institutions that are actually issuing these patents have also declined dramatically. This just points the spotlight on the fact that we might want to divert more R&D resources towards this area if we want to have future growth in not only innovations but also the economic benefits that might come from the R&D investments. Yeah.
Okay. Someone asked about the reason for the decline in expenditure. So is it possible average expenditure per member has declined due to the insurance companies paying providers and hospitals less? It's possible. Again, unfortunately, we can't say one way or the other what's really driving this. It's if you think about what entails expenditures, it's price, it's quantity, and it's the underlying conditions of the members, right? Of the people who are diagnosed with these conditions. So any one of those things could explain this. It could be that the price is changing. It could be that that utilization is changing. Although I think were we able to hold the group of people constant from year to year, I don't think that's enough probably to explain the significant decline we saw this year in expenditures for coronary artery disease. So there may be other explanations that are involved with that too. But again, unfortunately, we don't have the opportunity, the availability to be able to pinpoint one specific explanation of that.
Yeah, I think the rest were duplicates in terms of opioid and asking about that.
All right.
Okay.
We're good.
Thank you.
Thank you.
Give them a round of applause. We are going to ask our presenters to come up here, and Diane will put their cards down. We're going to go alphabetically so that we can do it in that order. I have the distinct pleasure of introducing today's expert panelist. We are very fortunate to have this esteemed group. Each panel member has outstanding accomplishments, multiple awards, and an extensive resume. And I could go on forever, but I'm not going to because we want to hear from them. So to maximize my time, or our time, I'm going to just go over the basic pieces about them, and then you'll see from their presentations how much of an expert each of them are. Again, I will go alphabetically. Our first panelist will be Rob Casalou, who is the President and CEO of Trinity Health Michigan Region. This region was formed in January 2018 when St. Joe's Mercy Health System and Mercy Health West Michigan joined together as a statewide region. Combined, Trinity Health Michigan has 10 outpatient health centers, 12 emergency departments, 17 urgent care facilities, and employs more than 20,000 individuals, including approximately 3,600 physicians. Rob first joined St. Joseph in 2008 as president and CEO of both St. Joe's Mercy Ann Arbor and Livingston hospitals, which made the top 100 top hospital list 7 times under his leadership. In 2015, he was named the regional president and CEO of St. Joe's. Rob is widely recognized as a national leader in his quality and compassionate care. He earned a Bachelor's of Arts in Economics, a Master's in Business Administration, and a Master's of Health Service Administration from the University of Michigan. Our second presenter will be Tina Freese-Decker, who is the President and CEO of Spectrum Health Systems, a $6.5 billion nationally recognized health system that includes a medical group, health insurance company, and multiple hospitals. Tina is focused on growth, innovation, and strengthening community partnerships to best address health disparities and health improvement goals across the state of Michigan. During her 16 years serving Spectrum Health in various roles, Tina has developed a strong reputation for her forward thinking, visionary strategies, and sound business practices. Her unique breadth and depth of experience includes leadership roles in strategy and orientation and operation across the systems. Today, Tina is the proud recipient of the Modern Healthcare Top 25 CEO in 2018. She earned a Bachelor's of Science in Finance from Iowa State University and graduated with a Master's of Health Administration, and Industrial Engineering from University of Iowa. Our final speaker will be Dr. Rakesh Pai. He is the president of the medical group and chief population health officer at Metro Health, University of Michigan Health, an award-winning leader in community health care. Metro Health serves more than 250,000 patients annually from across West Michigan and beyond. Dr. Pai is a cardiologist with certifications in clinical cardiac electrophysiology and cardiovascular disease. He previously practiced in Idaho, Nevada, and Oregon, where he served as Executive Medical Director for Regents Blue Cross Blue Shield of Oregon and Director of Population Health Management. He is a fellow with the American College of Cardiology and served on the Board of Trustees for the Oregon Medical Association. His medical degree is from the University of New Mexico School of Medicine. He has completed a Master's of Business Administration at the University of Tennessee Haslam College of Business and a Master of Healthcare Delivery Science degree at Dartmouth College. Please welcome Rob to the podium.
Well, good morning. It is a pleasure for me to be here, and particularly with my colleagues, Dr. Pai and Tina, and with all of you here this morning. One note on Trinity Health. Trinity Health is the only national health system that's actually headquartered in the state of Michigan. So Michigan region, it's one of our larger regions, and then Livonia is our national home, and then we're in 22 states and the fourth largest health system in the country. So it's been great to join this family, and I'm not going to spend much time talking about a commercial around our system, more about what we're here for today, and that's a forecast. A couple disclosures that I like to always start with. One, and I've said this in other audiences, you know, when you're in a career path in health and hospital administration, you hope that you leave things better than when you started. And I would say in terms of our organization as a business and the health systems that we run, there's been a lot of success. But really, I would declare that I'm a little frustrated and embarrassed that in the 25 years that I've been leading organizations, the communities we serve, and you saw some of the statistics earlier this morning, are not as healthy as when we started. That's not anything any of us want to put on our resume. My career goal really is simply for individuals to enjoy life and enjoy those things that they look forward to. And that's what I hope we're in the business to do. I do align with Trinity's mission to be a transforming and healing presence in the communities we serve. It includes personal health, but also includes the local economies that we reside in. And I'll talk more about that in a moment. A few assertions that I'll also make before I get to the actual forecast. The landscape's changing. This is kind of Captain Obvious statement here, but the landscape's changing, and all of us who have a theory will line up against someone else who has a different theory. It's really been very hard to keep up with, whether it's on the policy side in Washington or just the consumer side. I think the laws of economics have finally arrived in our industry because if you look at our industry dating back to the Hill-Burton Act, we've basically designed the U.S. health system around legislation for 70 years. And that legislation was basically dictating how we got paid. And so we designed our systems to do a great job of getting paid very well, particularly on sick care. When we look at what's the product people wanted to buy, not sure we delivered on that, because I'm not sure people want to buy hospital care and health care and sick care. But we've done a really good job, and I think some of the numbers we show in terms of our expenses as a country, and you can see on this last bullet point that, you know, we got away with things until we started consuming too much of the country's gross domestic product. And when you start hitting 20% of a nation's GDP, you're becoming a burden to business, you're becoming a burden to consumers. The ACA is always a hot topic. I make an assertion here. People may disagree. It was not the catalyst of change. That's not a political statement. It's just an opinion. But I think it was a law created in response to undeniable economic issues and access issues in our country. So a few questions that I ponder. Is our new favorite term population health? Is it about the economics of healthcare or really about truly improving the health of the population? Said another way, are we developing strategies for our hospitals and health systems, those of us up here and others in the room and around the state and country, on how to survive the transition and make a margin, or truly around population health and improving health? And I think that's a question we all have to look in the mirror and answer. Are we trying to survive the transition and have a business model that survives, or are we actually making a difference in the population? And you know, there's an economic definition for all the economists here. If you're a product nobody wants to buy, but you're a product that people need, you're oil. You're a commodity. Health systems have had a hard time accepting that in some ways we're a product nobody wants to buy, but we're needed. And it's hard to look in the mirror and say, you know, we might be commoditized in a future health delivery system. Now, I'm not saying we're going to be, but these are just kind of provocative questions I like to ask in these kinds of settings. So how are we doing with the population health? Is our population getting better or worse? Well, you saw some of the statistics, so I don't need to go over those. Have we developed a culture of health in our local communities? See some disparities between East and West Michigan. I would have loved a slide that overlaid the issues and social determinants of health in Wayne, Oakland, and Macomb County and Kent County. Because we don't talk a lot about that, but when you look at other countries that have decided to, and I'm not here to propose Medicare for all, and I'm not doing any of that, but some countries have decided to nationalize their health systems. If you look at the cost, it's very low in a lot of those countries now, but they invest heavily in social determinants. And so you have to look at the total cost there. But anyway, that's just the slide I'd love to see sometime to match up against some of the things we saw this morning. If the United States is the most expensive country in the world for healthcare, are we number one in health? No. We're way down the list. So we're not getting what we're paying for. And why am I asking you all these questions that you already know the answer to? I think it's because we know what's happening. We know what's happening, and we either don't know what to do, we don't care. I don't think that's really the case. We figure we'll just keep treating illness and make a good living doing it, or we'll keep failing in our attempts to change the deteriorating health of the population. We keep trying new things, and we just don't seem to be moving the needle. I'm going to blow through this one. This is because you already talked about obesity, and just for kicks, when you see the big spike in obesity back in the 70s, it was in 1976 that McDonald's introduced supersizing. Just saying, and you can see handheld games started in the mid 80s, and so I don't know. There might be something to that. Our rap sheet in Michigan isn't good. I'll just let you look at these. Correlates a little bit to the statistics you saw already this morning. So economics, socioeconomic. So I think right now we know health is costly, particularly poor health, and you can see some of the numbers here. Even as a person who doesn't exercise, higher costs. Diabetes alone, 33% of adults without a high school degree are obese. Now we'll go back to social determinants, education, poverty, these sorts of things are creating disparities in health. And 33% of adults earning less than $15K per year are obese compared to roughly 25% who earn at least $50,000. And there's race disparities as well. All right, so my last slide on the forecast. I think right now I'm still seeing a medical arms race amongst all the health systems who compete. Part of that is still investing in the acute side of care and putting our billboards up on the latest technologies we have and that sort. I think I still see that. Now I see it shifting a little bit, that our balance sheets, which a lot of us were largely full of bricks and mortar hospitals, we have 8 of them in Michigan for Trinity Health, most of that investment's moved quickly to ambulatory and physician group development. One comment on the physician comment about why in Michigan do we have a preponderance of employment of doctors more than other parts of the country. I liked the answer on care coordination and everything, but also Michigan is particularly stressed in getting people to live here, and also incomes are hard to maintain in Michigan compared to other states for doctors, so they come for employment to maintain competitiveness as well. Having said that, Like in Trinity, Michigan, we're going to open 17 new ambulatory centers in the next 3 years. We are redoing a hospital in Muskegon, but by and large, most of our investment is in ambulatory and trying to move that care out. Payers and providers. We have Blue Cross and Priority in the room today. I think payers and providers are trying to feel each other out here, what the future is going to look like. Who is the primary relationship with the patient? Is it the insurer? Is it the provider? That answer varies depending, and it's answered by all of us individually, but both business models are trying to vie for their position in this new era. Industry consolidation, meaning health industry, I think will continue. We've seen a lot of it here in West Michigan, a lot of independent hospitals joining other hospitals, Spectrum, others. East Michigan, same thing. I think that will continue as standalone hospitals and standalone practices have a hard time surviving on their own. I think the new entrants, we didn't talk about the new entrants because they haven't been able to measure their impact yet, but wait till Amazon and Google them really get going. I think they're going to focus on cost, they're going to focus on service, and I think they're going to really put health systems in the bullseye, and appropriately so, by the way. I think they are going to bring a new value, and we have to figure out how to work with those disruptors that are coming in. And then employers, some of you in the room, I think employers have been beyond lost patience with the cost of care. I think that now they're looking at everything they can do to lower healthcare costs. Some of that was shifting burden to their employees. Now direct contracting is becoming much more prevalent, where they're saying, you know what, cutting out the middleman, I'm just going straight to a provider. I'm going to only provide limited choice, and I'm going to move all the risk to the providers. I think that this is going to probably be the one thing you see if we're standing here a year from now that there's been a lot of traction on in the state of Michigan. So with that, I'll stop and turn it over to Tina.
Well, good morning. I'm pleased to be here today with you. And like I said, I'm Tina Freese-Decker. I'm the president and CEO of Spectrum Health. And when you think about Spectrum Health, you may think about the hospital on the hill here in Grand Rapids. I'm extremely proud of all of our physicians and caregivers and team members, our hospitals and our insurance plans. But we are more than just the hospital on the hill. And we are transforming and changing the way care is delivered, because we want to make sure that it is personalized, that it is simple, affordable, and exceptional to meet all the trends that Rob just talked about, because we see those forces coming forward, and we need to make sure that we can do what we need to do to improve the health of our communities that we serve here. And so it's very important that we are transforming from not just a traditional hospital to a health system that is really focused on a healthier you. So to do that, we are really focused on how we get our 30,000 people together in a unifying approach and purpose. And so we're spending a lot of time on culture, because I believe that to provide the best care and the best coverage, we must have the best culture and the best environment to do so. And so our focus is on creating that culture. And a key element of the culture that we're focusing on is collaboration. So as I've started in this role for the past 4 months, I've focused on our culture of trust and transparency and a culture of cultivating the finest talent. And I think the common element of that is how we work together, showing that vulnerability and trust when working together and creating that collaboration. Because trust and transparency will empower the collaboration, and having people really working together on a common goal will continue to embrace and fuel more collaboration as we go forward. And we want to ensure that we have collaboration that's both internal and external, because that will help us move much faster in addressing the health needs of our community. So today I wanted to highlight a few areas of collaboration that I think are successful, but we need to continue to move forward with those. And so the first one is our collaboration, our community collaborative on infant mortality. This is the Strong Beginnings program that many of the organizations in this room are part of. And it's one where we've come together to work with mothers and fathers and their babies to reduce the infant mortality rate. And we have been successful in this. You can see on the chart that it goes down from 1.53 to 0.92. That means we have eliminated the disparity between African American infant mortality and Caucasian women. That's substantial. to do that in the last 3 years and the last 10 years overall. And part of this is because we've worked together to put practices in place on peer support groups and to really engage with best practice. This number is something we should continue to push to drive down. We need to drive down the total infant mortality, as well as if we're achieving these results, only 46% of the people are in this program. So we need to engage more people in that program so we can have a significant impact on our community. This is an area where collaboration has really helped us because we've joined together across our health systems to make sure we're making an impact and connecting on the social determinants of health. The other area that's really key in our community that we're focusing on is opioids. We mentioned it today in the discussion, and we're focusing on how do we address this nationwide crisis here. We recognize that this is a big issue. I recognize that Spectrum Health cannot do this alone. It takes all of our partners. And many of us at the table here have worked together to put together best practices, education, and toolkits to address the issues. We are coming out with internal scorecards, so we better understand the prescription patterns of our providers and can give them education on how to improve. We have collaborated on how we use our respective medical record systems to make sure that we don't prescribe medications for longer than 7 days. We are implementing across all of our emergency departments the alternative to opioids process so that we, again, limit the opioids. And as was said earlier, that's just one aspect of our strategy to address the opioid crisis, but it's one that we can work together on and collaborate. And so as you can see in this chart here, it shows Priority Health members utilizing opioids for the last 9 months. And we can see the trend is going down. And although I don't have the death information for this, like we talked about earlier, I think this is a key measure to show the leading trends, and hopefully then the lagging trends will show that the death rates and mortality will follow this same trend. Again, we needed to do this collaboratively with all of our partners here because we have to be focused on the same things to address the health issues of our community. And this is one area that we're focusing on, as well as behavioral health, in a full collaborative because it takes all of us to do that. The next area I want to focus on is about costs. If you talk to anybody in healthcare, and Rob's presentation hit it exactly right, was that the cost of healthcare is just unsustainable. It's completely unaffordable for people to address costs. So this will take the best minds coming together to really think about how do we reduce the cost of care. And so an example that I want to show you is Spectrum Health home-based care. And we've worked in a collaborative manner in our community, whether it's the Spectrum Health home-based care, it's Tandem 365, it's Affinity, it's others that have really focused on how do we apply best practices to reduce the cost of care. This is specifically for a population that is the highest cost populations, the frail elderly. It's those that have the chronic diseases. And instead, typically what happens is they go into the emergency department, they then get admitted, they then go to skilled nursing facility, and that follows every few weeks. And so our focus is let's get in early. Let's get engaged with this population so that we can make sure that we can do things appropriately. So now they have access to every week someone visits them in their home, and then if they do have a health issue that flares up, they call 24/7 access, and we can help them determine what the best options are. As you can see from the results, we have decreased utilization, and we have increased the satisfaction, we've increased the outcomes, and we've decreased the costs because of this program. And again, this program, as well as the other programs that we have for home-based care or trying to reduce costs, we're sharing the best practices because we all need to learn together to make a difference in reducing the total cost of care for our community. This is one example of low-tech, high-touch that is reducing costs. But an example of high-tech that's reducing costs is our cardiovascular simulation lab. We have the only dedicated cardiovascular simulation lab in the country. It's where our residents and our fellows can come together to learn the best techniques and practice on customized mannequins to do their craft really, really well. A couple months ago, we performed one of the first surgeries in West Michigan here, and instead of just going to the OR and doing it, we actually went into the cardiovascular simulation lab with teams of physicians, anesthesiologists, nurses, and techs, and practiced on the personalized programmed mannequins to make sure we knew what we were doing well. We learned what roles people needed to play. We learned what equipment we should use or not use. And so then the following day when we went into the OR, we were so much more confident because we'd already performed the procedure on that patient's anatomy. And we were able to do it in less time and use less equipment, so we reduced the cost of care. Again, that's an example of using some innovation, taking the time to make sure we're doing it right, that will then reduce the cost of care. So I think that this innovation, this work on social determinants of health, the work on engaging our people on what we're doing is absolutely imperative as we go forward, because there are so many trends coming at us. We need to really be focused on what we can do well and drive towards those outcomes that will really matter. Our focus is to make sure that we improve health, to inspire hope, and to save lives. We really believe to do that we have to provide a more personalized health approach, one that is simple, one that is affordable, really looking at the cost of healthcare, and one that is exceptional. We all demand to make sure that we have the highest outcomes possible. And I believe that although this is going to be very hard to do, it's going to take a lot of time, effort, perseverance, and collaboration by many people here. I believe that we have the right tools, we have the right technology, and we have the right people here, both internal to our organizations, but also because we are unique in our community where we want to collaborate with others to really drive this forward and make it happen. I think that collaboration is the key element of this, of how we're going to make it a difference and how this community can move us forward to be successful. So I usually quote someone, either Helen Keller, and today I'll quote Mother Teresa. I believe that you can do what I cannot do, I can do what you cannot do, but together we can do great things. And that's the power of collaboration. Thank you.
All right, well, good morning, everyone. I'm new to the West Michigan area, and I think I started my position around the time that Tina was appointed CEO. What a great turnout today. It's super exciting to be here. So I'm going to be talking about the calculating value in healthcare, the importance of the consumer experience. So it's going to be maybe a little bit different compared to my predecessors. So this is the healthcare buzz, and I often tell audiences as when I'm in front of large groups like that there's no better time to be born in the United States than today. Just recently, this last year, 2018, we graduated the first class of medical students that have been updated on terms such as the quadruple aim and population health. I think of population health as, imagine this room is full of diabetics, right? All 500 of you have this disease. How can we make sure everyone gets the right care at the right time and doesn't fall through the cracks? Diabetes is a very chronic condition that if it's left untreated for a number of years, you could end up with something like end-stage renal disease. It's the #1 driver of end-stage renal disease, and if we have any employers in the audience, we know that that is one of the most expensive diseases, end-stage renal disease. So making sure everyone gets the right care at the right time is really important. I think the other 2 bullet points here are also very important. It's super exciting. One would be the genomics revolution and how that drives personalized medicine. I think that's going to be extremely awesome for patients, meaning that we can take the patient's genetic material, know what mutations they have, and then offer them treatment based on their very specific genetic mutation. So that's very, very exciting for healthcare. So this isn't going to just be kind of down the road a number of years from now. These concepts are coming today. And so what are some of the trends in healthcare? Well, I think healthcare is the largest sector of our economy. Over $3.5 trillion almost is spent on healthcare. It's consuming, as Rob alluded to, 20% almost of GDP. So it gets a lot of press. And so I think some of the things on the left are super exciting. And we'll talk about this New York Times article in a little more detail about why the U.S. spends so much more on healthcare compared to other nations. But I think the Blues and Priority and other payers in our market have done a nice job of marching us along that pathway to paying for outcomes instead of paying for procedures. So that's really important. I think regionally, we've alluded to it a number of times already today, opiates is a huge issue. It's the first time American life expectancy has not gone up is due to suicides and opiate overdose. It's very, very unfortunate. It is a health crisis. But interestingly, the MLive article there in the middle, most opiates actually go to people with behavioral health conditions, which may not be the right group of people to be receiving heroin in a pill, if you will, which is what opiates are. Also, it's not a big city issue. It's not just a Detroit problem. It's obviously a problem here in Grand Rapids and West Michigan. And all delivery systems and payers have to be at the table to reduce that. And there have been good results. I do think technology is going to be very, very interesting in disrupting the healthcare industry, and we'll talk about that in more detail. I think patient-generated data from your Apple Watch. Who has an Apple Watch on? I have mine, right? So I think that's really important. The Apple Watch has the ability to now record a heart tracing. You can know what rhythm you're in. That's super exciting. I think as providers, we have to do a better job of incorporating that data. How many steps are you taking? How active are you? What's your EKG tracing? Those are all very interesting things that patients, we can get that data on patients in real time. So I think that's super exciting. Also, the genomics revolution I alluded to earlier, we had our first gene therapy released in the fall of 2017. That drug costs $1 million for treatment. It's actually taking the patient's cell out of the body, weaponizing those cells, and infusing them back into the patient to attack a cancer. So that was the first gene therapy. It came out in the fall of 2017. There's going to be a lot more treatments like that coming down the pike. I think it's really exciting. So there is one equation, okay, and it's an easy one, so this is it. The healthcare value equation, and I think this helps articulate the quadruple aim, the right care at the right time with the right consumer experience. So I think this equation is extremely important. CX's consumer value is what's the relative worth, utility, or importance of the service that's been received, and that equals the quality divided by the cost. Plus, you can have a positive consumer experience or you can have a negative consumer experience. So in the next subsequent slides, I'm going to kind of go through some of these things as it relates to Metro Health. So on the quality front, we're really trying to improve the health of our communities. And I think Rob and Tina did a nice job of highlighting all the things that they're doing at their institutions, and we're at the table as well. Depression screening, we do know, and Dr. Callison was talking about this earlier, if you have a mental health condition and a chronic disease, your utilization patterns go way up. You use the ER more, you're in the hospital more, you're in the, you have poorer outcomes with your disease because of that mental health condition. So we have dramatically increased depression screening using our EMR to reach more and more patients to make sure they get that screening so that we can begin them on treatment. The last 4 bullet points really have to do with making sure patients with heart disease that come to our hospital with a myocardial infarction or a heart attack get to the cath lab as quickly as possible, because time is muscle. And then if we're able to get them to the cath lab very quickly, we can decrease their mortality rates. And we need to recognize them as having an acute coronary syndrome or a heart attack very early. So as soon as they present to the emergency room, we have to get them that EKG. It's very, very important. Now, we've dramatically improved this over the last 5 years, but it's still, some of these metrics aren't exactly at 100%. We need to do better. I will say that our comprehensive stroke program, which Dr. Hahn highlighted last year, that program has grown very significantly. And also we're able to get our patients that have a stroke, that present with the stroke, into the lab within 30 minutes, and that dramatically improves their outcomes. So that's another important thing about how we're improving quality for some of these diseases. Next, on cost, Metro Health has done a pretty good job with costs over time. We want to be a low-cost leader. Of course, we're not low-cost in everything. There was a recent article that came out in MLive within the last few days that kind of highlighted some of our costs with respect to obstetrics care or pneumonia or cesarean sections, and Metro does pretty well being a low-cost leader in that regard. But this slide basically talks about the per member per month costs, PMPM costs, comparing this. We got this data from one of our payer partners. Other health plan providers are a bit more expensive, $420 per member per month versus Metro, which is around $400. Now these costs have been slowly going up, and I get that. This is the rub amongst employers, that healthcare costs continue to go up, yet profits in their businesses don't go up as quickly. And so that's really important. We talked about West Michigan does pretty well with costs. However, in the United States, we do not do very well with costs. And Rob had alluded to this earlier. We spend about $10,225 on healthcare per person in the United States. That's almost twice as much as other countries. In West Michigan, that number is a little bit lower, around $9,500. So why is healthcare more expensive in the US? Well, this article came out in January of 2018, New York Times article. Aaron Carroll is a pediatrician and an economist at the University of Indiana. And the real reason that costs are high in the US, it's prices. It's not that we use more healthcare services compared to Germany or Switzerland or the United Kingdom. It's the prices that we charge consumers in this country. So why are the prices high? I think the prices are high because it's a very, very complex healthcare ecosystem. So if you look at the top, those are all the things, all the different stakeholders that consume healthcare resources. Medical device industry, the pharmaceutical industry, Kevin had talked about that, providers, hospitals, and clinic delivery systems for sure, and patients. And then you can see at the bottom, those are the paying entities, the sort of the commercial payers, employers, which are self-funded, of course, and Medicare and Medicaid. And putting pressure on all these, this ecosystem is all this innovation. How do we pay for $1 million gene treatment for hemophilia or sickle cell disease? That's some of the pressures that we have today. So I think one thing that's really important to focus on is the last part of that equation, the experience. And as we all know as consumers, how we consume things has changed dramatically. How we check in for a flight, how we order something online and it's delivered to your door. It's extremely exciting. So I very simply have broken down a healthcare journey into the pre-care episode, the actual care delivery episode, and the post-care episode. And I think by and large, it's not necessarily easy for the right patient to find the right type of physician or hospital delivery system for them. We don't have one resource that says who's the lowest cost, best quality provider in my area for this. It's not so crystal clear or transparent sometimes. But most patients find that provider that they have confidence in. They get what they need and they get the outcome that they're supposed to get. Say if they get a knee replacement, they go back to work pretty quickly. But where we really, really lack is the post-care experience, right? The consumer experience is very fragmented and it's confusing. So what's wrong with the post-care experience? Well, this is what's wrong with it. The post-care experience is very negative because we actually cause financial harm to patients. Like this is data from the GoFundMe website. Some of you are familiar with that. People are raising more than $650 million on GoFundMe for rising healthcare costs. Charity is not the solution for rising healthcare costs. So you get a lot of bills after you get out of the hospital. You get them from several different places. Some of them say they're not bills. Some of them are bills. And they can keep, yeah, that's very confusing, right? And it can keep going for months after you had whatever it is that you had. So it's very confusing to people. And GoFundMe is a resource for them. So what has, we're in this awkward dance where we have care delivery. How do we deliver care to patients and payment reform? And we've sort of been doing this awkward dance for a number of years. I do think the care delivery model has really evolved itself with a care team approach. Physicians recognizing like, look, I'm not the best diabetes educator. I'm not a social worker. I'm not a pharmacist. And so we're sort of parsing some of that out to those different members of the care team to take better care of patients. I do think the payment reform model has struggled to some degree. We're continuing to do more value-based things, but it hasn't evolved as quickly as the care delivery piece, in my opinion. So this is my forecast piece. So this is what I think is going to happen in healthcare because it's happened in other industries, and I see no reason why it wouldn't here. If you look at growth over time, healthcare has sort of had this slow, incremental, kind of tortoise-like evolution or change. And if you look at the hare or the rabbit, innovation is really exponential at this point. Think about social media. Like, was that something that existed a few years ago? Your iPhone, right? It came into play in 2007. So the gap here between sort of the hare and the turtle is really this innovation piece. And I think it's really driven by consumer obsession. And companies like all these players on this slide are doing very, very innovative things in the healthcare space. Just to highlight, the picture here, this is Seattle, Washington. On the right panel, you can see the Space Needle down there, kind of downtown. And these two large buildings on the left panels here, looking down on those spheres, that's Amazon. And Jeff Bezos sits in that building that's right in front of the sphere. He sits at the very top of that, and that building's called Day One. So Day One is his orientation that they're always looking very far down the future, and they're really looking at large total addressable markets, and absolutely healthcare is got to be in their sights. So I'm out of time, but I just wanted to highlight that a lot of these companies on this slide are doing very innovative things, and the last message I want to leave the audience with is that we as healthcare leaders need to really disrupt ourselves, or we will be disrupted. All right, thank you.
Those were all exceptional presentations. Thank you. But now we're going to start the Q&A. And I think any of you could answer these questions. The first one is, give examples of how Amazon will disrupt healthcare.
Okay, I'll take a shot. Well, they have an infrastructure of delivery that is unparalleled. We can get something tomorrow, even sometimes today, and I think they will leverage that to provide services around pharmaceuticals, around other kinds of things that we sell in this industry, and kind of master the delivery process of that.
I'd agree with what Rob said. They have the platform to deliver. They have a significant supply chain platform that can really expand anywhere you are. But I also think that they have really focused on the consumer experience. It is so easy to click and buy it. And if we think about our bill payment process, it is anything but easy. So I think that they are ahead of how we connect with consumers, and we see them entering into every little business that can get into healthcare. And so I expect that they, as well as Google and Apple, will be major players in healthcare.
I would say I see them with the Prime benefits kind of evolving that. There could be different tiers on top of that. There could be a healthcare tier. You can have so many telehealth visits. You can have so many same-day delivery for pills. You can have, they could be a large purchaser of pharmaceuticals and command a rather significant discount. If you have, 100 million subscribers, that's very, very powerful to the pharmaceutical industry. Just today, Johnson & Johnson raised their price on 250 drugs, 7%. A lot of them have been doing that this year. So Amazon would definitely put a pricing pressure on that component if they went full bore into pharmacy.
What do you make of the telehealth data, and what's the future for telehealth for each of your organizations?
We've started telehealth. It's been going for 4 or 5 years now, and it increases by over 50%. Last year, if you just look at January, we increased by like 300% because we really targeted the flu population so that they would stay out of the emergency rooms and we could talk to them via telephonically. So I expect that telemedicine will grow, not just in the direct-to-consumer low acuity services, but also in the specialty areas. And I think we'll be doing more things of how do we connect more with people in their home, using their home devices, whether it's their current TVs, whether it's their current technology. But I think that this will continue to grow. Eventually, telemedicine will be just like anything else. We won't call it digital health, it'll just be health. But today we have to call it that way because we have to think differently, and we have to make sure we're thinking digitally first instead of thinking in a physical format right now.
Yeah, I'd agree with Tina, and I think that it's got many venues where it gets used now and will in the future, connecting rural areas, being able to bring specialty care. We're the hub for the Michigan Stroke Network. We're able to bring that expertise out into the field through telehealth. I do believe, the virtual visit thing, was a little slow on the uptake in some markets, and go back to economics, it wasn't getting paid for, so it wasn't getting done. Now, because we're taking risk for an episode of care and we're trying to do everything we can to lower that, now suddenly the virtual visits, at least in our networks, are growing exponentially because it's a way to manage care outside of the office, outside of the hospital.
Yeah, I agree. I think it's definitely a pervasive trend. I think it will be the way that care will just be delivered, and we won't make that distinction that Tina just called out. Admittedly, we're a little bit behind at M.H.A. and University of Michigan Health, but I do think the telehealth consumer, interfacing with the consumer is really going to be important. But I also think that telemedicine component, care teams talking to care teams via sort of a video interface, is going to be really, really important. To know whether or not we need to really transfer a patient or can we keep them where we have them. We can call the University of Michigan through that sort of a platform and make sure that we're all on the same page without having to translocate families. I think that's going to be really important as well.
Gene therapy was mentioned by Dr. Pai. What do you see as the role of the employer on patient coverage decisions, and do you see any trends regarding employers directly involved with those coverage decisions due to the high cost?
I've seen examples of employers trying to interject in decisions like that, and we absolutely get that. it's very, very hard to budget for, you know, a $1 million treatment when your plan is maybe, you know, $10 million to spend a year. You're a medium-sized company, that's what you spend, and then 10% of that's going to go to one person. You know, we totally get that that's a challenge, and you can't raise prices fast enough to cover that. But I would really be hesitant to get involved with those kinds of decisions. It's very tricky. The indications are usually pretty tight when they come out. The plans do a good job of having the research departments apply the policy to the trials when the drug was studied. So I would tend to stay out of that. But I think you could address it through other mechanisms like a reinsurance type product, you know, making sure you have stop loss and things like that above a certain threshold could protect you financially to some degree.
I think it'll be interesting to look at this longitudinally, because if we can really target something that impacts your health and do it earlier and do it the right way, the first way, then that will impact the total cost of care in future years. But today, our environment revolves around an annual insurance and an annual process of the way we look at it. So we're not really incented or motivated to do it that way. But I really think that this is the long-term play, but we have to make sure we understand how that all comes together in the 1 year that we do this. And that'll be the changing environment. I also think that there's so much going on, not just in the genetics, and there's cures that are finding, or we're able to put people, especially pediatrics, in remissions right now. But there's also a real focus on pharmacogenomics, because right now the data shows, and there was an article in Nature that shows that the pharmaceuticals that we commonly take don't work for most of the population. And so if we can really drive into that, maybe that will make an impact, because we won't be spending so much on those medications. We'll actually be spending on the things that actually work for us. And so I think that's a big thing that we need to focus on over the next few years.
You know, I think that, some of the answer to this question will depend. Some of the self-funded employers probably get a little more involved in what's deciding it's covered or not. More would I say, and we're an employer too, we're a self-funded employer. We absolutely look at those things that we cover. But more important, the focus is on benefit design and on the site of care. I think that's where I see the employers getting, flexing their muscles now, and that is, where are the incentives for preventative care, trying to move employees towards the lower end of care by providing the best incentives, or healthy lifestyles. If they're willing to live a healthy lifestyle, lower premiums are out of pocket. And then this direct-to-employer or working with the payers on narrow networks, limiting choice and trying to lower costs. That's where I see more of the emphasis, more than this is what we're going to cover and not cover.
We've talked a lot about sick people and trying to get them well. A question is there ways to change that paradigm and start trying to focus on the well people to keep them healthy? How does that get paid for? How do we bring in community help? How can this work so we have more healthy people?
So we are focused on health and wellness, trying to find new ways to promote healthy behaviors. We've started a culinary medicine program at Spectrum Health where we are helping people learn how to cook, how to shop for healthy food, and how to bring that in place. And then we can have the conversations, whether it's in our lifestyle medicine or in our primary care practices, where we talk about how nutrition and exercise and all those go into play over the person's lifetime to make sure that they are focused on the direction that we need to go.
Yeah, I would just say, you know, good health is not an accident. I imagine anyone in this room who considers itself healthy, good BMI, great metrics on the blood and all that, you probably worked to get there. And I think part of what's incumbent on us in healthcare is to try to continue to encourage that through information, telehealth, easy access, so that maintenance can definitely be part of it. And I'll still circle back to social determinants, because at some point, even people who are healthy face some barriers. I'll give you an example. We do a social determinant screening on every primary care visit in one of our groups in East Michigan, a group called M.H.A. We screened 55,000 patients in the last few months, and found that social isolation was the #1 social determinant. That can hit a healthy person very quickly and start to evolve into other issues. So I still want to come back to the fact that with this, as a community, we need to get our arms around that issue.
I think I would say I really want healthcare to transition away from healthcare to just keeping people healthy. And I think that the payment reform model has to pivot a little more. I mean, I would love to build something at Metro, and looking at my team here in the middle, that if we received a per member per month fee to work with a certain population that didn't have known chronic disease, but the focus would be on keeping them healthy. What kinds of things could we really create if we could think that way? How many steps are you taking? And we notice you haven't been as active recently. Is there something going on in your life you haven't interacted with us in this amount of time? So we can pick up on those things in real time. I think it could be and it wouldn't necessarily have to be that high cost. It's just interacting and keeping people engaged in their health and making all those hundreds of decisions each day that you have to make to keep yourself healthy and avoid obesity or being overweight, for example, that are really, really key. A lot of it is all of these chronic diseases are behavioral driven, and this would sort of be a behavioral driven program trying to motivate people to make right choices.
A question is there a provider and nursing shortage? And if so, are they affecting our quality outcomes? And what are our solutions?
I mean, I'll start this and you guys can kind of jump in. I think we got about 1 million physicians in the United States, and they used to be kind of categorized into 4 different age groups, and I'm not going to go through that for this purpose, but each of those age bands had about 25% population. So we had 25% of our physicians that were above the age of 60, 25% above the age of 50. That's now shifted significantly, where we have almost 30 or 35% of our physicians greater than 60 in this country, which means 300,000 to 350,000 physicians are within 5 years of being 60, and we all know what happens at 60. There's going to be a dramatic. All right, fair enough. They're going to retire. All right, you got it. But so we have an aging of our physician population, and that's going to have a big impact. And so I think there's been movements towards doctors of nurse practitioning and PAs and other APPs kind of filling in. I mean, I think there'll be more of that in the future. Its impact on outcomes, I'm not sure that's been a real significant issue yet, but could potentially be down the road.
The skill set of our physicians and our nurses and other caregivers is absolutely important as we transform the way care is delivered. We need their expertise, not only to connect with the patients and the people that we serve, but also to help guide us to figure out how to reduce variation, to really make sure we're doing the right things in our practices, because it just can't sit on their backs to do so. We need to have health coaches. We need to have more community health workers in the homes. So I think it's this true partnership and collaboration for all the caregivers, and we need to figure out the right mix and model for that, but I think it will evolve over time.
One thing, we're in the midst of a great nursing program here at Grand Valley, and there's others around the state. And it's interesting, we talk about the nursing shortage, but some of the conversation we have with the schools is we can't place all our new grads. What's the problem? The problem is if you look where the shortages are, they're primarily in areas like ER, ICU, and OR, where you don't typically start a new grad. Generally, you start them somewhere else, and you kind of grow them into those more intense areas. So then, all of a sudden, the schools come back and say, we thought there was a shortage, and we can't place some of these new grads. The solution has been really, we've had to change our training and change our thinking in the hospitals to allow new grads to move into those areas sooner and be buddied and be trained kind of real time in those more intense areas where those shortages exist. So that's one issue. On the provider side, really quickly, just say, yeah, there's a shortage. I think telehealth, we just talked about, is a way to be able to spread somebody's expertise in a broader, more efficient way. Trying to reduce demand is a way to deal with the provider shortage. If to the extent we can move care away from specialties and things like that, that would help that as well.
Wonderful. I have a handful of questions, but we only have time for one last one, so we're going to take this one. What is, in your opinions, what is the next collaborative effort our community needs to do in health?
We need to focus on behavioral health. So it's a huge issue. We've been separating it from the physical health for far too long, and there are many, many people working on this area, and they're doing great work, but we need to come together and really put forward a strong plan that will provide access, provide greater help for the people in our communities to address behavioral health issues, because that goes to every other issue related to their health, their medical needs as well.
Yep. No, absolutely. Yeah.
Okay, any last comments from anyone?
Thank you for having us here. This is a great opportunity to talk to a lot of folks who are going to make decisions in this community, and hope we provided some value to you and some thought-provoking questions.
Thank you.
Thank you.
Thank you for all for attended, and if you take a look, our next health forum is organ transplant and donation, and it's the first Friday of February.